you're currently the director of breast imaging here at Hopkins. What is a typical day like for you in that role?
Yeah, so good. It's never boring.
Sure.
That's for sure. In breast imaging, I know we think of a lot of radiologists as sitting in a dark room reading images. In breast imaging, we do that to some degree, but we also see patients and we discuss their results. We discuss the findings, whether or not they need a biopsy. And our role really is to send women off on a journey, unfortunately, fairly frequently, too frequently, of breast cancer care. We have a schedule much like other primary care providers, and there are challenges with that, but also the pleasures that come with that. Each day there's a question that comes up that we don't necessarily know the answer to. Literally, I think every day this occurs. And so it gives us ideas. How can we improve what we do? How can we answer those questions? So some part of each day also shapes the research that we choose to do in breast imaging. We have a very limited amount of time when we meet a patient to have a complicated conversation, often medically complicated conversation with someone we've never met before.
Yeah.
So there hasn't been an opportunity for an interaction that is necessarily lower stress, that lays a groundwork and a foundation for a relationship. So when you walk in the door, one has to have a conversation with a patient, one has to make a judgment of how that interaction is going to work. If you sit down and you're sitting at the same level as the patient speaking with them, there's just an ability for patients to relax more and feel that you have enough time.
You've worked to improve breast imaging not only here at Hopkins, but in Haiti, in South Africa, and Uganda. What are the challenges of breast cancer in the developing world?
Globally, only about half of women in the world have access to any detection, diagnosis, or treatment of breast cancer, which is pretty startling. Right now, most women who are diagnosed in low-resource areas with breast cancer present at late stage and, in essence, have a death sentence. And so their care becomes not necessarily treatment, but maybe palliative care. I've thought about that a lot. We have a lot of ideas and research components that we're looking at, but we're very, very fortunate where we live that we have opportunities for early detection for a disease which is frequently curable when detected early.
Finally, you believe that the meaning of medicine only comes for those who seek it out. What is that meaning to you?
That meaning for me is what do I take home from my patient interactions? And that might be medical knowledge, but more typically that is just more personal growth and the ability to observe people in challenging, stressful situations who handle them so gracefully.
Okay, Dr. Harvey, thanks so much for your time.
You're welcome.
That was A CLOSLER Look.